Hello everyone. I can't believe it's already time for the 2024 guideline updates, but 2023 is behind us and we're looking forward to a new year. I know last year was very busy. We've had some of the sickest patients, highest acuity trauma, severely sick respiratory patients, and you guys all have done a wonderful job. So I want to start by just saying thank you. Thank you for your hard work. Thank you for the care that you provide to our community and to our patients. Thank you for continuing to learn and push yourself to be better. I just can't express enough how grateful I am for all that you do. As we look forward to this year, things that are new in the guidelines, there really aren't that many, but one that you will see is an inhalation guideline. This is just to help discern different kinds of treatments between maybe carbon monoxide, cyanide, and then different biological or chemical agents, chlorine, phosgene, stuff like that. Same really principles are the same with airway management, supply oxygen if you need to, positive pressure with BVM or CPAP, and then continue to the hospital. But if there are some antidotes you need to consider, we've listed those out for you depending on the exposure and the inhalation hazard. So hopefully you find this helpful, and it should be coming soon this year, so keep your eyes out for it. The next one I just want to emphasize, we're seeing an increase in pediatric mental health crisis, unfortunately. And sometimes these children can be very, very young. And so in coordination with our pediatric emergency experts and our toxicology experts, we've come up with a guideline that has some dosing for agitated, severely agitated children. I'd like to emphasize with our pediatric population, always the first step should be an effort at verbal de-escalation if you can. And most of the time that should work. Special consideration here for our autistic population. If you have a child who is on the autism spectrum, if they have home medications that they can take, there's an allowance for that in the guidelines. Sometimes these are either Benadryl or Clonidine or something along those lines. If you have a family member or a caretaker there who can help administer those, that would be ideal. If they're past the point of being able to take their own medication, we do have we've been gifted some bags for autistic children that have different things to help distract them or maybe calm them down. So fidget spinners, headphones, things to bring down the level of stimulation. Those should be in your trucks. If they're not on your trucks, please ask for them. And if you can't find them or they're not available, ask 7-8. They do have one on their truck too. Now, if you've tried home medications, verbal de-escalation, different kinds of distracting mechanisms for these children, if you get to the point where they're a danger to themselves or danger to others, scoring a 6 or 7 on the Behavioral Severity Index scale, this is the point where you probably need to start thinking about chemical restraint. We always want to do this as safe as possible. Our only option for chemical restraint in pediatric patients is Versed. I know we have droperidol, but that's simply for adults. So Versed is your only option. We'll be going intramuscular with this. And if the child is less than 13 years old or less than 50 kilograms, the dosing is 0.1 milligrams per kilogram. I realize that we have some large, say 10 or 11-year-olds out there or adolescents, large 14 or 15-year-olds still fall in this pediatric population, and so we've made an allowance in the formulary and the guideline that if they are basically an adult weight and need adult dosing, you can follow the adult dosing on the Behavioral Severity Index for those children that are a little bit larger and may need heftier doses for sedation. As always, I would encourage you, especially with children, please start low and go slow. You want to not overdose them. You can always give more medication if you need to, but it's hard to take it back once it's in. And as always, please be sure to monitor their airway and have them on capnography after the sedation is complete. That's really it for the new guidelines or the guideline updates. There is some really exciting literature this year I wanted to share with you and just emphasize some key points about patient care. These are some of my favorite articles this year that I think are important for us to know. So the first one is regarding amiodarone in cardiac arrest. So as you know, we give amiodarone in our shockable rhythms, VTAC, VFib, shortly after we deliver our shock, ideally. This study looked at outcomes in patients who received an antiarrhythmic earlier in the code as opposed to late. And what they discovered is that if you can get your amiodarone on in a shockable rhythm in the first 8 minutes, there's increased likelihood of ROSC, increased likelihood of survival to discharge, and most importantly, this is like the holy grail of cardiac arrest, right? What we're looking for is functional neurological survival. And this study found that if you get your amiodarone on in those first 8 minutes, you increase the likelihood of all of those things. So this year, we do such a good job on cardiac arrest, and we're so good at pit crew CPR, but this year I'd really like to emphasize getting that antiarrhythmic on board as early as possible in these arrests to help improve our neurologically intact survival rates. Another pretty exciting study, and I think we're already doing this, I just wanted to emphasize it, is placing the pads on STEMI patients. I think it's inherently obvious, but they went ahead and studied it, so now we have scientific proof that it helps. But we know STEMIs are inherently unstable. They can devolve into rhythms that are dangerous or even a cardiac arrest. And so when you identify a STEMI, if you could place the pads on these patients early, that way, if they do devolve into a cardiac arrest or a shockable rhythm, you're already ready. It's going to decrease your time to shock and increase their likelihood of survival. So please place the pads on your STEMI patients early. And also remember, the minute on scene that you identify, you get that 12 lead, you get it early, you recognize a STEMI, please call from the scene to the hospital to let them know that you're coming with a STEMI patient. This helps them activate their cath lab staff and get them ready for the patient who's going to be arriving, and just accelerates the time that they can get their stent and get their heart reperfused. Very important. Next, this is another exciting study. We pace not too infrequently for bradycardia. And what this study looked at is pad placement in bradycardic patients that require pacing. So these are unstable bradycardic patients, either after or prior to atropine administration. And this study showed that if you are able to place the pads in an anterior-posterior position, so one pad on the front, one pad on the back, they had almost a 78% capture rate. And the most important thing I found interesting in this study is that females, they captured 100% of female bradycardic patients by placing the pads in the anterior-posterior position, as opposed to the anterior-lateral position where they only captured 42% of the time. So I don't know about you, but pacing can be stressful, it can be frustrating, and it's also a little painful to the patient. And what they showed here was that they get captured faster and with less electricity, which is less pain for the patient, more effectively with anterior-posterior pad placement. So please consider this pad positioning the next time you find yourself having to pace somebody. Now, it kind of begs the question, well, what about cardiac arrest? Is AP pad placement better just for straight VTAC or VFib? And that hasn't really proven out in the literature yet. So for now, we're just emphasizing this pad placement for bradycardic patients. More to follow on ideal pad placement for other rhythms. But this is a good one to remember, and I think you'll find good success with it here. This is one of my favorites, and I honestly have been dying to try this myself in the emergency department. It's just that most SVT patients get converted by EMS before I get to them, and haven't had a chance to try this one yet. But it is a promising take on a Valsalva maneuver for patients who are in supraventricular tachycardia, and it's called the reverse Valsalva maneuver. So patients who are in SVT right now, I know we typically have them try to bear down or blow on a syringe and move the plunger forward by increasing that intrathoracic pressure. Well, this is actually a backwards maneuver. You have the patient, assuming they're stable and you're not needing to cardiovert, what you can do is have them plug their nose, and then just like the picture demonstrates here, have them breathe out first, plug their nose, close their mouth, and then try to breathe in while their nose is closed and their mouth is closed, and it increases introthoracic pressure. And this particular study had a pretty incredible conversion rate with this type of Valsalva maneuver. And I'm very excited to hear from you guys out there if it actually starts working, because based on this study, it looks like it has almost twice the conversion rate of other typical vagal maneuvers that we've tried in the past. Next, this is not in the guidelines, but I just thought it was interesting and maybe something that you could keep in your hip pocket if you ever encounter this. And I don't know how many of you have encountered it, but a bleeding dialysis fistula can be pretty stressful and is a lot of bleeding. And this is something that I learned from a nephrologist, and they actually reported a case study in the American Journal of Emergency Medicine this year, where you can actually take a bottle cap, any bottle cap from a water bottle or a Coke bottle or whatever. They've actually started manufacturing these as keychains for dialysis patients, so they have them on them if they have a spontaneous bleed. As always, for any kind of uncontrollable bleeding, we want to try direct pressure. But if you're having a hard time controlling bleeding from these AV fistulas, because they can be a little bit bigger, these bottle caps have proven effective in the past. And you just hold them over the site that's bleeding, and you can either use Coban or your finger like you see depicted here in the picture, and hopefully that will help stop the bleeding. Just something to consider if you ever encounter one of these. We didn't put it in the guidelines because I don't know that it needs to necessarily change our practice, but it is definitely allowed, and it's a good way to control bleeding here. Minor edits that you should be aware of, but I don't know need their own slide or their own discussion. Really, we're at the point where we're just kind of cleaning up the guidelines and making little edits. For the LVAD guideline, we have some of our LVAD patients who receive their cardiac care out of state, so we included the option to call their out-of-state coordinator instead of just the heart hospital coordinator who is here in town. These patients, if they do get transported, will still need to go to the heart hospital, but if you call their personal coordinator, they're probably more familiar with their medical history and their personal situation, so it's okay to call whatever coordinator number that patient has on them and tells you to call. Medical aid in dying, I'm sure some of you are aware that there were some laws passed this year where patients who have a terminal diagnosis and a terminal condition can decide when and where and how they want to die. We made a little bit of we didn't really change the guideline, and I don't expect that you guys are going to encounter this at all. They have very robust wraparound services, but wanted to just update the guideline to include the medical aid in dying for those folks out there who decide to take control over when and where and how they die. For pediatrics, there were two updates that we had. One is that there are different kind of AEDs in our system between Bernalillo County, AAS, AFR, and some of our partner agencies, Corrales, Kirtland, and just made an update for the pediatrics who are less than 1 year old. Just follow the manufacturer guidelines in terms of how and when to defibrillate infants. Hopefully that never happens. I honestly can't remember the last time we had a shockable rhythm in an infant, which is a good thing. But just follow the manufacturer recommendations on your AED for these small children. Speaking of shockable rhythms for pediatric cardiac arrests, after further review of the PALS guidelines, we've removed any amiodarone or lidocaine from pediatric cardiac arrest algorithms. It's not really recommended. The truth is, again, like I mentioned before, we hardly ever see shockable rhythms in these children. But if you do, shock if appropriate, continue your good CPR and your ventilations like normal. Just we're not administering antiarrhythmics. You still give epinephrine, but no antiarrhythmics in these kids. Couple other minor updates. Some folks in our system are carrying a pre-mixed bag of magnesium for preeclamptic patients that has 4 grams in a 250 cc underfill. We made an allowance for that. Nothing is going to change about our mag concentration or administration. Just made an allowance for different types of concentrations that are out there. And then For COVID, we had some fentanyl and ketamine infusions, anticipating some longer transports for intubated patients. We no longer need those guidelines, so we removed the continuous infusions for post-intubation sedation, and then tried to clean up the miscellaneous guidelines in the appendices, so it's just a little bit cleaner when you're looking at your guidelines. Those are really the major edits this year. Now we're on to just points I want to emphasize that we've seen as trends over the last year, or questions that have come up that are actually really good, that gave us some pause to think about. Number one is tourniquet use. We have a marked increase in the general population and APD actually, who are placing tourniquets on patients who are bleeding, which is a great thing. We know that stopping bleeding early can save lives, and so the more tourniquets and bleeding control equipment that are out there is a great thing. But also with that comes some patients who have inappropriately placed tourniquets in the population, and the classic teaching has always been, once a tourniquet is on, don't take it off. Well, we've reached a point where you guys are the medical professionals, and it is okay for you to assess that tourniquet. We actually updated the guideline that if you think that tourniquet is ineffective, number one, is there still pulsatile bleeding and that tourniquet's not doing anything, you can move it or replace it or adjust it as needed. Number two, if it's clearly not required and somebody just saw some bleeding and got a little nervous and put a tourniquet on, but it's a very superficial wound, it's okay to take the tourniquet off in that circumstance to reassess the bleeding. Again, you guys are the medical professionals. Tourniquets, as you know, are very painful, and so if the tourniquet is causing more harm than good on a superficial wound, go ahead and take it down. If you're really not sure, if you're trying to assess a wound and you can't tell if it's profuse bleeding or if it's pulsatile or if it needs a tourniquet, go ahead, assuming it's appropriately placed, go ahead and just loosen it, assess the bleeding, because you're going to get asked about the bleeding at the hospital. If it is profuse or it's pumping or you think it's arterial or it's just hard to control, go ahead and tighten it back. But if it isn't, then you can go ahead and loosen it if the patient doesn't really need it. Okay, use your judgment there. You guys are the bleeding experts, and you can use your assessment skills to decide whether or not a tourniquet is needed. Of course, if the tourniquet is improperly positioned or it's over clothing or it's just not effective and they do need a tourniquet, please go ahead and adjust that as necessary. Cut the clothes, put it in the right position. That is okay. Our goal is to stop bleeding, and you can assess that and correct it. I would like to mention that gunshot wounds in particular, please be careful with these, because a lot of times these are the ones where you're not going to see pulsatile bleeding. Maybe all you'll see is a hole, and you'll not be able to tell. Especially important for the lower extremities. So the one exception to this, where you take it down and assess for pulsatile bleeding, please, on gunshot wounds or stabbings to the extremities, if your patient has any hint of instability at all, please put that tourniquet on. I've seen several patients die from gunshot wounds to the legs where the hole looks pretty innocuous, but they have hit an artery or have severe bleeding into the thigh, and it is difficult to see. So if you have someone with a gunshot wound or a penetrating injury to the upper legs or the arms, please go ahead and use that tourniquet. This is the one exception to these rules where you can take it off and reassess. For gunshot wounds, you're not going to see profuse bleeding. You just need to suspect that it's there. I hope that's clear. Just a reminder that Albuquerque Ambulance has a special skill for intermediates to administer benzos. This is a good thing. It helps us with some of our alcohol withdrawal patients. It gives them more ability to sedate agitated patients and can also help with treating seizures. This does not mean that our intermediates at AFR can give benzos. Just don't be surprised if you see Albuquerque Ambulance doing it. The same rules apply that after a chemical restraint or administration of a benzodiazepine, we still need to closely monitor the airway and use capnography. And these exceptions are in the guidelines for Albuquerque Ambulance. If you have any questions, please let me know about this, but wanted to just get it on your radar that you may see some intermediates out there administering these medications. Quick reminder about STEMIs and hospital capabilities. This list has been updated. specifically Rust Hospital with Presbyterian now has a 24/7 cath lab. So our STEMI receiving centers are Presbyterian Downtown, Presbyterian Rust, Heart Hospital, UNM, Main Hospital, and the VA most of the time, but I would advise you to call ahead and just make sure their cath lab is available. Those are your options for your STEMI patients. And remember, you're going to be putting those pads on them and calling a STEMI alert early, right? That is about it. Just a reminder on some other little trends that we're seeing in the field. Probably about once a month, we're having pediatric patients, and I mean like toddlers, anywhere from 3 years old to an infant, who somehow are getting exposed to narcotics or fentanyl. If you get dispatched to a child who is acting inappropriately or is unresponsive, and a lot of times these dispatch codes are for seizures or choking or altered mental status, if they're just not acting appropriately, please consider giving them Narcan and a full dose. Don't just give them a baby dose, give them their full dose of Narcan, as well as checking a sugar in these altered kids. You're not going to cause any harm by giving them Narcan, and you may actually help. So just, it's unfortunate that we live in a time where you need to keep this on your radar, but there is so much fentanyl in our community right now. These kids are being exposed, and we're seeing a lot of this. So just keep it in the back of your mind when you encounter a child that you're not sure what's going on. You can't rely on their pupils. Their pupils are not always going to be pinpoint. So I would base this decision mostly on their mental status and their respiratory status. But keep in mind, you're not going to cause harm. So if you're not sure what's going on, go ahead and try it. Another note, we're seeing more epinephrine given IM for respiratory distress patients. I would just like to encourage you to be very cautious about giving IM epinephrine to our respiratory distress patients, especially our elderly population. Epinephrine is a very potent drug. It's a potent vasoconstrictor. It does help open up the lungs, but it also causes constriction in blood vessels. And where that can be a problem in our elderly population or our older population is that it can lead to strokes and actually STEMIs. And so I would encourage you, unless you truly think that your patient is going to arrest right in front of you from a respiratory problem, please try your other interventions first. So if you have a patient with severe COPD, they're in severe respiratory distress, they're tripoding, they can only speak in 1 or 2 word sentences, get that CPAP on there early, get your continuous duonebs going, give them some Dex, give them some MAG, and give that a couple of minutes to see if you can turn them around. Now, if you really feel like they are about to collapse and pass out and go into cardiac arrest, that's when you use your epi, if it's truly respiratory failure. But until that point, please reserve your epi until all your other modalities have been tried. The one exception to early epinephrine is true anaphylaxis. So if you have a patient, remember we define anaphylaxis with 2 system involvement. This is an acute onset of an exposure to an allergen. Those are the first 2 things you need. Then you can look for your other systems, whether it's skin and they have hives or airway swelling, or remember GI symptoms can be predominant. Once you have 2 symptoms in anaphylaxis, then give your IM epi. That's the one case where you move to epinephrine early rather than waiting. But for your respiratory patients, please be cautious. Another thing that we're seeing, and I just want to kind of get on your radar because it's easy to overlook or maybe not think about, is bradycardia. Whenever you have a bradycardic patient, please take a second to ask yourself if it could be hyperkalemia. The end stage of severe hyper-K is bradycardia, and what you'll see is a very, very wide, complex QRS, just like you see here, a bradycardic rhythm, and some peak T waves, just like you see here. Now, why this is important to consider bradycardia and possible hyperkalemia is because your treatment algorithms are completely different. As you know, if this is just straightforward bradycardia, you're going to be thinking atropine. If they're unstable, you're thinking about pacing. If they're still hypotensive after pacing, you may be thinking about epinephrine, which is all the right things to think about. But if it's hyper K, atropine, pacing, and epi are not going to help that potassium level. And so the treatments for severe hyper K, as you know, are 15 milligrams of albuterol that is nebulized. That's going to help move the potassium into the cell, get it out of the bloodstream where it's acting like a poison. And if you see this wide, slow QRS, please give calcium. Calcium is the thing that's going to stabilize the myocardium, and it's really interesting when you give this in hyper K because you can actually see the QRS start to narrow right in front of you. Albuterol has the side effect of increasing the heart rate, so you may see your bradycardia resolve right in front of your eyes. Just please consider, if it looks like a really weird bradycardia to you or there's any reason the patient may have hyper K, please add this to your Rolodex of your bradycardic patients and consider the need to treat hyperkalemia, because otherwise, if you go down the bradycardia pathway, you're going to completely miss the hyper K treatments, and this patient may code on you. Just another point to emphasize is that Levophed is the preferred pressor in cardiogenic shock, especially for our post-ROSC patients. This helps, again, our goal, remember, is neurologically intact survival, not just ROSC. And so Levophed seems to be better than that, better for neurologically intact survival. Epinephrine, like I mentioned before, tends to be a very potent constrictor of blood vessels, which can be particularly bad for the brain, and Levophed seems to be a little bit gentler there and is better for neuroprotective strategies. So please get your Levophed drip ready for your ROSC patients or severe cardiogenic shock. And also, Levophed is very good for sepsis. So if you find yourself with a septic patient who's hypotensive tachycardic with a obvious source of infection, remember that Levophed is a nice option there too. Please remember, we also have ECMO available. Mobile ECMO can come to the scene. The earlier the better. You want to run that checklist the minute you arrive on scene. Hopefully the alarm room has already prompted you to start thinking about this, but mobile ECMO is generally available Monday through Friday from about 8 to about 5. There should be an announcement every day with that particular day's availability. Remember, though, if you don't have mobile ECMO available, the hospitals still have it. So if you recognize these candidates early, witnessed arrest, bystander CPR, not a respiratory arrest with an early shockable rhythm, please get those patients moving. If you're within 35 minutes of a hospital, they can put them on ECMO in the hospital, and this will greatly increase their chance of survival and intervenable causes of their cardiac arrest. Certificates for evaluation. I know a lot of our questions tend to revolve around our interactions with law enforcement and who's responsible for which patients. I'd just like to clarify on these certificates for evaluation that if you arrive on a scene for a mental health evaluation or where APD is showing you a certificate for evaluation, this is strictly a law enforcement order. The way I think of it is basically just like an arrest warrant that PD has. This is a medical arrest warrant where they've been told by a physician to bring a patient in to be evaluated. It's up to them to get them there. Now, if you find yourself on these scenes and the patient clearly has a medical complaint or a medical problem and is going to need medical clearance before they can go to the psychiatric facility, then we can get involved in patient care. But these patients still have the right to refuse medical care if they want to. We do not have to transport them. This order does not trump our guidelines. So our refusal criteria is the same. Our patient care expectations are the same. And if there's any questions, please call 78, or you can call an MSUP as well. We deal with these issues on a fairly frequent basis and can help navigate the interagency dialogue there. And another just reminder for lower acuity psychiatric patients who are just calling for help but are relatively stable and cooperative, a nice alternative to transport is ACS. They can come to the scene and take that patient to the facility that they need to, assuming they don't need to go to the emergency room or need medical care. If they're straightforward psychiatric complaint, ACS can take them. Another nice option for patients that meet refusal criteria and are staying on scene is 988. This is a crisis hotline with actual trained providers that can talk to them and get them set up with care in the next couple of days with a therapist or counseling or whatever they need. And then another nice option for our psychiatric patients that kind of fall in the gray area of can we force them, should we not, I'm not sure. Mobile crisis teams. You can check and see if they're available. And what's nice about this is it actually brings a mental health clinician to the scene along with law enforcement who can do the assessment right there. And so the patient doesn't have to leave their home, doesn't have to spend all night in the ER. The assessment can happen right on scene and they can decide whether or not they stay or have to go. A really nice option for those patients who fall in the gray area on forcing them to go or not. I would just like to ask if you could please, on your documentation, use your drop downs for either procedures or medications that you administer. We do collect a lot of data. Specifically this year, we've had a lot of questions revolving around how often we're having to give Narcan, and also when and where and how sick our gunshot wound patients are. And it's really helpful trying to track this data if you've used the drop downs for your procedures and your medications. You guys overall are doing a very good job on your documentation. Your narratives are excellent. You're getting several sets of vitals. You're uploading your 12 leads. I'm very pleased with where we are in terms of documentation. I would just ask that you please continue to use those drop downs if you can, and also be as specific as you can about the provider impression with what's going on with your patient. We tried to make those a little bit clearer this year with different types of overdoses or what you think is happening, but that also helps us search when we're trying to collect aggregate data of what's actually going on in our city. Don't forget to do your cross-checks. Very, very important for medications. You want to make sure you have the right patient, right dose, right time, right route, and check with your partner. We work in some very stressful situations, and it can get hectic sometimes, and nobody likes to do math, especially under pressure. So it's not a sign of weakness. It's actually a good thing to just have your partner there check your math, check your dosing, and make sure we're doing the right thing for our patient. If you do find yourself in a situation where you haven't done your math correctly or you've misadministered something, please just be honest about it. First and foremost, monitor your patient, watch for those side effects that you may anticipate, then report that to whoever is receiving the patient in handoff, and then submit through the QA process so the QA cadre can get involved and help troubleshoot any issues that may have arisen from that. Last thing, I just want to emphasize, it's getting a little dangerous on our streets. I'm sure you're way more aware of this than I am, but I do worry about you guys and I want you to stay safe. So please, safety first. If you have any concerns about going into a scene or interacting with a patient that's not safe, please wait for law enforcement to get there. You got to take care of yourself first. And then second is just please consider your situational awareness too. And take care of yourself. I worry about you guys. I'm proud of the work that you're doing. If you do encounter any issues where you have a violent patient or have experienced any type of provider assault, please, like I mentioned before, we're trying to collect data. We know that provider assaults are happening with increasing frequency both in EMS and in the hospital. Please report that. We can't cumulatively do much about that unless we know how big the problem is. And so by you taking the effort to report anytime that you're assaulted, it really helps us build the case for more legislation and intervention for these patients who are behaving badly towards providers. And that's all for this year. I hope 2024 will be a really good year for all of us. You guys are doing a great job, and I hope you can keep up the good work, and I'm just grateful for all that you do.